If you're hoping to live to 120 or older like I am, then you're going to enjoy this episode. Now, there's a lot of misconceptions and overhyped products and protocols within the longevity space, but a lot of people forget about the core foundations and the most important things when we're talking about longevity, often, trying to avoid dying, because that's going to end our longevity journey pretty soon. So today I had the pleasure of chatting with my friend, Dr. Simon Baarbe, who's the medical director and head concierge doctor at Total Fusion Australia. And Simon's unique career began in the world of private intelligence, where his investigative acumen and analytical approaches to finding truth within swaths of discordant data contributed to landmark victories in New York Supreme Court and the Manhattan District Attorney's Office, and other public and private entities in investigations of organized crime, fraud, and corruption. That same reverence for truth, critical reasoning, and an outside-the-box engineering problem-solving approach is now the foundation of his medical and professional passion, a strategic, proactive, evidence-informed application of longevity science, empowering clients to shift their odds in favor of living as well as they can for as long as humanly possible. In this episode, we cover a lot of different things about longevity, starting from the investigations and things that you should be looking to do from a preventative-based approach, and different types of tests that many places aren't doing, including whole body MRI, CT angiograms, pulse wave velocity, which is something a lot of people aren't familiar with. And then, of course, we talk about the core foundations of longevity, covering lifestyle, nutrition, exercise. And then we also get into a few of the more nuanced topics, things like rapamycin and metformin, and we give our opinions about where they are. All right, so I hope you enjoy this episode with Dr. Simon Baarbe. As usual, make sure you like and subscribe if you enjoy the content so you don't miss out on any future episodes. All right. Thanks for dropping by so we can do this podcast together.
Absolutely.
So obviously I'll do a little bit of an intro about you, but It's always nice to dive in and get a bit more of your background and what you do. So I'd love to start off with, I guess, a bit of your background, how you got into medicine, even a bit before that, and then we can kind of get into more of the longevity stuff and some of the more fun topics.
Excellent. All right. I'm super old. I don't know where you want to start, but came to medicine by a very indirect and inefficient path. Originally studied engineering, decided that wasn't for me, worked in the private investigative intelligence space in New York for some time, before eventually having a change of heart. It's a very long story. Fought and screamed and kicked my way into medicine.
Nice.
And
sounds appropriate.
Yeah, it turned out, I did it to myself, so I can't complain about being here. It turned out to not be exactly what I always or had previously assumed it would be, but having been through it, I've now got the privilege of getting to try to do medicine the way I felt like it should always have been done.
Yeah, excellent. I want to pull that apart a little bit more. There's two things I kind of want to dive into there. One is the engineering background, which is really important, and maybe people who are familiar with Peter Attia, that's usually the easiest thing to reference. You would take a very different approach to how you view medicine, because traditionally engineering is a very sort of systematic approach and system view towards things, whereas medicine had gone sort of the reductionist view. So maybe I'd like to open that up a little bit, and how that allows you to view things differently when you look at medicine and disease and all those types of things.
So I think the biggest picture, looking at the problem from an engineering point of view, is actually looking at it from an economics point of view. Resource allocation. How much time, how much money, what are we dealing with, what do we value, how do we allocate what towards what to get the outcomes we desire? And from a zoomed out viewpoint, I've always felt like that's not quite happening the way I envisioned it should be.
How so?
We put a tremendous amount of time, effort, and money into mitigating age-related chronic disease after it occurs, when I truly believe for a little less time, less money, less effort, front-loading, we could delay the onset of many of those diseases, or strongly reduce the chances of some of them occurring as soon as they do.
So more preventative-based approach.
Exactly. That's the simplest way to put it.
Which we've talked about this many times. Like it seems common sense to approach things from that way, and there's been studies that looked at potential cost savings, let alone obviously the benefit to people and their health, but even from a financial perspective, it can save billions of dollars, but yet we're still in this sort of reactive based medical system. And
absolutely,
of course, you would know better than me that a lot of our current sort of allopathic conventional medical model is built on more addressing acute infectious disease and those types of things, which we did an amazing job addressing. But now we've sort of got this growing disease of modernity and affluence, whatever you want to call it, which it seems we're not tackling so well. And I think the preventative approach and even the longevity side of things can tie into that, because and I know people are fighting now to try to get longevity as a classified disease, because then it means we can treat it. And often if you address the things that improve longevity, you're often improving overall health, mortality, everything else. So it kind of ties into that whole preventative based approach.
Yeah, that's exactly what we're going for. But like you said, the reactive medicine is still amazing. Like, there's some amazing heroes where if things are going wrong, those are the people
if I need surgery, if I have some crazy disease or some, there's always a need for that. But I think there's definitely a gap in the area now with addressing the more lifestyle associated diseases.
Completely agree.
Which now so many of the things that are the top killers, which is something I'd like to talk to you more about, those we know a lot of the evidence now shows it's not so much genetic, maybe a small part of genetics, but so much of the big killers, cancer, cardiovascular disease, now neurodegenerative disease, Alzheimer's, things like that, dog going in the background. A lot of those we know are associated with significant lifestyle factors that are modifiable lifestyle factors.
Yeah, and nothing's a guarantee, but I'm confident in a lot of cases we can shift a person's odds, which why wouldn't you if you could?
Yeah. And so I guess how does that tie into the next thing I wanted to ask you of, like, where did you find, when you were going through your training and you got into medicine, where did you find the discordance was for you? Like, what did you not like about what you saw that was kind of happening in that space?
Where do I even start?
Without doxing people.
I mean, I do need to preface it by saying there's a lot I like. I learned so much from some amazing people about how to treat some things acutely that absolutely life-saving. But in that, I would note other things. So say someone would come into the emergency department with this or that condition, and they'd be in their 50s and have abysmal kidney function, and sort of situation where you'd be shocked if they made it to 70. To me, that's the next emergency. But in the emergency environment, the leg's splintered up. Let's get him out of here.
Only so many beds in the hospital.
Exactly. And I'd find myself going home and studying, how do I prevent kidney failure? How do I preserve kidney function into long life? How do I preserve it into old age? Because that's the thing that the people I was surrounded by weren't focusing on. Whereas there's no shortage of people that knew how to patch that leg up, put it back together, just as I was learning.
Yeah. Do you find that's still the case? Because I feel I'm often in this echo chamber, and maybe you are now too, where I feel like there's a growing amount of people that are having that mindset change now to this more preventative approach, but it seems like there's still so many doctors, I guess, just going down the traditional pathway into the hospitals, and they don't broaden their horizons into these other areas. And I'm sure a lot of that is due to the way academia is set up, but also the way insurance is set up. But do you find people are spreading more into that, or is still...
it's hard to say, because the more time I spend in your world, the more people I know and meet in your world. Sorry, microphone. The more it seems like more and more people are going down that path, but I don't know if it's just my time in that space versus that's what's actually happening. I do still locum in hospitals on occasion to stay current, and I can say from that viewpoint it doesn't seem to have changed. Frankly, nor should it. When you've got one pressing issue and that's the biggest issue, and you've got to get that
focus
right.
on that.
Yes. But then outside of hospital, I think
it seems that's where the discrepancy is, right? Like, we've got that allopathic model in the hospitals, which is great for patching people up and keeping them alive, but then we kind of send them out, and then the continuum of care seems to not continue there, which is unfortunate. So I think I've had these talks with other people too, and that's where I think some of the more natural medicine or allied health practitioners need to fill the role more because it seems there's already a shortage of doctors and they can only do so much. So maybe that needs to fill up with other practitioners that are trained adequately.
And I think what you're saying more as well as around the model of care, not so much the specific background that someone may have had if they trained in natural medicine or this or that. It's the ability for someone to have that patchway between what's happening in someone's life versus what's happening in the GP office versus the hospital. Everyone needs a great GP. Everyone needs access to a hospital.
I was gonna say, I guess the GP is supposed to be that primary care provider that sort of toes the line between those spaces.
And they do in some really great ways, but there's some other ways in which they just don't have the capacity in these 10-minute appointments where you've got to get people in and out. And so that's why I'm saying it's more the provision model than the actual nuances of, is this a natural practitioner or this or that.
And I think that's a much broader public health sort of discussion, which I'm sure we could go down a rabbit hole, but let's not go down that one today. We can open that one another day. I want to sort of pick your brain a little bit more around longevity, because that's something that's super popular these days, and I'm very passionate about. Hoping to live to at least 120. We'll see if we can get there. Maybe 200.
So where they go?
We'll see.
Support that.
But I guess to broach that topic, what do you see as the sort of top things to focus on when looking at longevity?
I think of it almost like, I guess a good analogous model would be sculpting or wood carving. Before you start polishing the piece of stone, you've got to chip away at it and make it roughly the shape you want it first. So the basics would be fitness. So VO2 max, muscle mass. We know those are the top two measurable parameters that correlate with somebody's longevity, more than smoking status, more than blood pressure, more than all these other things we can measure. It's how good is your VO2 max? How much muscle mass do you have?
And I'll just pause you there because I want to put emphasis on that, because for a long time, and this is changing now because a lot of the experts, again, like Peter Attia, Rhonda Patrick, a few others now are espousing the same sort of thing. But for a very long time in the longevity space, that wasn't talked about that much. Like the fitness and exercise side, I think wasn't valued much. And so I'll just put a bookmark on that because I want to dive into a bit more around the importance of that, but then practically how do we sort of optimize those perspectives? But sorry to jump in. I'll let you finish.
Perfect. Where was I?
So I guess the important things around longevity.
It's got to start with the basics. If you don't have your fitness figured out, your sleep, reasonable nutrition, there's no point worrying about the weird and the wonderful and the magic pills and the potions and the supplements.
And I want to dive into some of those with you because I think it's human nature where it's always shiny object syndrome.
Absolutely.
And in the age of like social media and all these online gurus now, it seems everyone's sort of pushing the latest pill or the latest treatment or the latest whatever, but they haven't gotten their foundations. But even before that, and we've talked about this before, and it's sort of a model that kind of have set up, but you know, what are the main killers of people? And then from there, the way that I view things is, all right, well, longevity is about first not dying, right, in my head. And so we need to consider what are the, biggest killers in Australia, worldwide, wherever, probably more relevant to being in like a westernized world. And then how do we go about stratifying that? Like, how do you know what your risk is? And then what can we do to reduce that risk? Because if you don't die, then that allows you to do all the other things to potentially extend lifespan, healthspan, etc. But obviously, if you die, then there goes your journey. So I guess for me, that's sort of step number one. So what are the big things that you want to focus on from a disease?
So if you look at it by age at which people pass away, when you're getting into middle age, it's about 50-50 heart disease versus a cancer. As you creep up into your 80s, assuming aspirationally you're planning to make it to your 80s, your incidence of heart disease far exceeds your likelihood of cancer being your cause of death. And the reason cancer plummets once you get into your 80s as a cause of death is because your likelihood of heart disease gets so much higher.
Yeah,
That
okay.
trend holds for Australia, for all developed countries, and developing countries as well. The biggest difference being in developing countries, you have more infectious disease and injury and things like that.
Yeah,
as
of
well.
course. I remember you showing me the reference article for
Yeah.
that and the graph, and it was quite a marked increase. Like
Yeah.
once you hit that point, then
Yeah.
it just skyrockets there. So okay, so cancer, heart disease, those
Yeah.
are sort of the
Those are the big ones. If we could take those off the table, then we'd
then
be doing
you've
well.
already done a huge part of
Absolutely.
enhancing lifespan.
Yeah. Yeah.
And
Absolutely.
I guess I don't want to go too much into cancer, but what's your perspectives around cancer? You know, lifestyle versus genetics. How much do you feel plays a role?
Yeah, I think just dumb luck plays the biggest role eventually.
Yeah, for a lot of things.
Yeah. It's a roll of the dice. The longer we're alive, the more likely something's going to go wrong within our genes. There are things we can do to influence it. We can't influence it as well as we can influence likelihood of cardiovascular disease, but
Yeah.
something not commonly spoke about is obesity being the second leading cause of the 13 most common cancers, only just second to smoking and not by very much.
Yeah.
Highly modifiable risk factor.
Extremely, and
Yeah.
this is a really concerning one nowadays because of the what's the term?
Healthy at any size.
Yeah, healthy at any size, like avoiding body issues and things
Yeah.
like that, where we know in the scientific literature,
Yeah.
obesity and diabetes is a significant risk factor for pretty much
Yeah.
all-cause mortality. Like
Independent
almost anything.
of blood pressure and lipids, still a 28% increase in cardiovascular disease.
Yeah, there seems to be this movement, and there's actually doctors part of this movement as
Yeah.
well, saying that it's perfectly fine to be overweight. You can be healthy and be overweight. And I guess overweight versus obese is different.
Yeah.
If you're in the obese classification, that's a stratification higher.
Yeah.
But yeah, there's definitely a concerning movement now in this PC world where I think we're accepting things where we know there's very clear data that it's going to increase your risk of disease
Absolutely.
and mortality.
And it's like smoking. You can smoke and be healthy up until the point that you're not.
Yeah. It's probabilities, right? Like it's always a probabilities game. So,
Yeah, definitely.
Yeah.
And yet navigating it, it's always difficult. I try to take the approach very similar to someone who might come to me and say, I want to quit smoking, or I'm trying to quit smoking, or I have quit smoking. And I would say, congratulations, that's wonderful. Good for you. How can we support you? And so I guess contrary to the criticism that might be viewed around the notion of fat shaming, if you do acknowledge the truth that there's a point where if you're large enough, you're not going to be particularly healthy no matter what you do.
Yeah.
Just kindness, compassion, encouragement.
Of course. Yeah.
And statistics. Like this is the harsh reality of what we're facing.
Yeah,
Let's address this
and
together.
that's where I get frustrated in that, again, people make it like you're either on this spectrum or this spectrum,
Yeah.
and there's no like in between. Like, yes, you can accept people and who they are and their character and persons
Yeah.
with still being able to recognize
Yeah.
the potential concern and detriments
Yeah.
to their health.
Yeah. Like I care about you. Let's help you not smoke.
Of course.
Yeah.
Yeah. I think come from it from the same perspective, but yeah, that's another one. I'm sure we can
Yeah.
continue. So, all right. So those are the two major.
Yeah.
What's your perspective on, I guess, the neurodegenerative side? Because that's a growing aspect.
Absolutely. That's a great question. So not a lot of people die of Alzheimer's disease. If you look at the hospital statistics or even see it in the hospital, heaps of people with Alzheimer's disease passing away, and it's usually pneumonia or aphasia or failure to thrive, and it's going to be listed as any one of those other things.
Yeah.
But
is one the proximate issue? Like, is the development of Alzheimer's increasing their likelihood and odds of developing all those other issues
Absolutely.
because now there's a lack of self-care and everything else?
Absolutely. And we know roughly 1 in 10 Australians die with Alzheimer's disease. Personally, it's my opinion, if I have Alzheimer's disease, I may as well be dead. If I can't remember my valued memories, the people I care about, form new memories. Exactly.
Yeah.
I'm gone at that point anyway. Yeah. Consider me dead.
And what people often don't consider, and this is not only for Alzheimer's, but just generally aging and poor aging, people don't consider, that affects you, and
Yeah.
great, you have Alzheimer's, you don't know what's going on,
Yeah.
but it also impacts everyone around you,
Yeah.
and your entire
Absolutely.
family and loved ones who now have to take care of you. And the dying process could be a couple of years or less, or it could be 20 years.
Yeah.
You could be in a home, you could now be in diapers. So people often don't think about that long-term perspective. They're like, oh, I'll care about it when I'm older. Like, well,
Yeah.
that process can be very long if you don't take care of yourself.
That's a really good point. Yeah, I don't think I've had many patients I've had that conversation with you.
No. And it's another one of those general human nature where we often are very short-sighted. We don't think about long-term consequences. It's all short-term gratification. We don't think long-term. I spent 5 weeks in my rotation when I was doing my degree for physio to be in an old care home, an aged care facility. And so that was eye-opening, right? Like, if you want to see what it potentially is going to be like for a very long part of your life, it's quite morbid, to be honest, and it's quite depressing. Like, it's hard to be in that scenario. And so I think it's tricky. It's always hard to get people to have that realization. But that's where I guess this longevity perspective comes in, is we can help move people away from that.
Yeah, it used to be really taboo to even mention the concept of Alzheimer's prevention, and now out of I think it's Cornell University, Weill Cornell Hospital, possibly.
Is that with Dale Bredesen and all his research? Or?
Yeah, I'm drawing a blank.
Yeah.
End of a long day. But I think even the Australian government puts out some good material about Alzheimer's prevention now, which only a handful of years ago was very taboo.
And it's another one of the things where medications is done quite poor as far as prevention and even treatment. Like, it hasn't really done much, sadly. And I think even a bunch of funding now has been pulled. But, okay, so those are sort of the main ones. And I think we touched on obesity, diabetes, overall like metabolic health, metabolic syndrome, because that sort of makes you more susceptible to everything. So the next step then is risk stratification. So what are your sort of like go-to things as far as determining someone's risk, whether they're a young person, an older person? What are some of the things that you look at? What's the process you would go through of trying to figure these things out?
So with our patients, we try to be as precise as we can, so it's quite a lengthy process, but we'll start with as detailed of a family history as we can possibly get, which is very arduous. It usually involves calling aunts and uncles and all kinds of random people.
Fun.
Figuring out, who passed away of what other diseases did they have, what medications might they have been using, why might they have been using these medications. But we've found that more useful than full genome sequencing, which we've played around with, we've looked at, but to get a lot of actionable data out of that isn't as great. So we've got an excellent detailed family history, number one, and then a personal medical history from that person as well. Every illness they've had, injury, everything they've been treated for. With all that, plus some good labs and a few other things, we can begin to put together a rough mortality risk assessment and go from there.
All right. So I know a lot of people are going to be curious about the labs part. So what sort of labs, a lot of people a lot of people don't go to their GP and get testing done until something goes wrong. But there's definitely a use case from that preventative approach. But there are often, tests that are covered under insurance, tests that are not. So what sort of tests are you looking at? And what are maybe some important and more esoteric, I guess, lab tests that people should consider getting, even if it's not under insurance?
Okay. I mean, there's the classic ApoB, LP(a), which people have heard ad nauseum, and you and I could debate this one for ages. Maybe some more esoteric ones that are probably the highest yield per effort would be an omega-3 index, determining what percentage of your red blood cells are comprised of omega-3s. And it's been found that people with a high omega-3 index who smoke tend to outlive people with a low omega-3 index who don't smoke.
It's powerful.
That's
super powerful.
Highly modifiable. Highly modifiable.
And I guess I imagine most people are going to know what that is, but for those who maybe aren't familiar, so you've got your omega-3, omega-6, which is part of your polyunsaturated sort of long-chain fatty acids, and the omega-3s have been shown to just generally be associated with positive health outcomes.
Absolutely.
At least particularly the ratio to omega-6 and omega-3.
You couldn't live without either, but
Yeah, but it's often vilified, and again, it's the dynamic of people always go to the extremes where like everything omega-6 is bad. But yeah, they do serve their own sort of role as well. Even inflammation, right? Like inflammation has a purpose.
we wouldn't be here
Oxidative
otherwise.
stress,
Yeah.
right? I think people often oversimplify these types of things of good, bad, and same with cholesterol, right? Like LDL good, HDL good, LDL bad.
Yeah, even in medical school, we remember it as the lousy DL and the happy DL.
There you go. Yeah, which, yeah, I'm sure we could go very deep into that one.
Yeah.
And maybe that's a good segue to talk a little bit about LDL, cholesterol, where that whole aspect plays a role in cardiovascular disease, heart disease, all those types of things for longevity.
Yeah. There's great epidemiological data. People with higher LDL cholesterol, the lousy DL, tend to have a higher incidence of atherosclerotic disease, clots within arteries, anywhere in the body, but when it shows up in the heart, that's going to get you first.
And what about the role, I guess, in like calcification? You know, a lot of people now are talking about calcium score. There's obviously now CT angiogram, which can give us a bit more detail. Where do those sort of investigations tie into the process?
Okay.
How important do you feel those are from a more preventative approach? Say someone like myself at 37 versus maybe an individual in his 50s.
Okay. I like how you frame that question. Someone like yourself. So say you came to me, you had a concern, or you just wanted to know what was going on. I do think it's quite reasonable to begin investigating in somebody your age, given that we know the disease process begins before birth.
Yeah,
makes
and
sense.
Atherosclerosis, we know, starts like that process starts very early.
Yeah.
So
before birth.
Yeah.
Yeah.
Okay. So even atherosclerosis before birth.
Yeah.
Wow.
Yeah. It's a constant process, so it's.
You've probably told me that before, but still, it comes as such a surprise when I hear it.
Yeah, it takes a while to show up, but there's been some famous autopsies of young people, Vietnam veterans, people in their 20s with atherosclerotic disease that surely wouldn't have presented as an issue until they're in their 40s, 50s, 60s, and so on. But it's there, and then that's a disease process that begins decades and decades prior to even showing up as a plaque.
So some of the things that I've been looking into with like Dave Feldman and the other doctors, John Kennedy, perhaps, and some of these other groups, there's the perspective of, that atherosclerotic process is there, and if there's blockages, if they happen slowly over time, the body naturally has an angiogenic process where it can branch off and continue the blood flow around the area, even for coronary arteries. How does that sort of factor into the whole process?
I wouldn't rely on it. I can't say I've ever seen an angiogram with a blockage where someone has then grown a whole new pathway for their blood.
But are you seeing someone that had an acute sudden blockage, like they had a myocardial infarct, or is this someone who it's been a progressive disease progression?
I mean, there is some adaptation in that other vessels will widen relative to the load.
Yeah.
But I can't say I've ever seen an angiogram where there's a bit of a blockage that looks like it's been there forever and a whole bunch of other stuff is going around it.
So then, thinking about that process, where does the preventative investigations come in? Is a calcium score sufficient? Because by the time something is calcified, it's usually a more stable long-term plaque versus CT angiogram is going to be able to pick up our more soft plaques, which may dislodge and cause issues. So
absolutely. So you and I have no doubt we'd likely have a calcium score of 0.
Yep.
But there's a very high probability that we'd have plaques visible on our angiograms. That's just completely normal for
most
guys
people
our
are going to
age.
have them. I guess it's the relative amount of and how sufficient they are.
Definitely. Now, is it worth us getting an angiogram? I don't think so. Even though we could, there's some very expensive angiograms that are incredibly low radiation yield that would be benign. It's not like...
they've been getting better and better now.
Yeah. But I still don't think it would be necessarily worth doing unless you had incredibly high ApoB, you were incredibly inflamed, you had really high blood pressure, all of the hallmarks that tell us this is going to go poorly. And then I knew the one thing that might change your mind from a behavioral point of view is to see a plaque having then formed on an angiogram.
Yeah.
Otherwise, I don't think it's worth doing the angiogram. Just
Yeah, okay. So unless there's significant risk factors there, it's not quite worthwhile going down that.
it depends on age, it depends on risk factors.
Yeah. So younger,
I've had an angiogram and I don't particularly have any high risk factors or
yeah. Yeah. So it's something where, because there's a lot of people in the
Yeah.
longevity space who have a lot of sort of indispensable cash
Yeah.
they could throw around.
Yeah.
If they've got the money and the interest,
Yeah.
is it worthwhile doing?
Um
Or is there potentially, like, is there a negative detriment? I'm always of the nature that more information is empowering.
yeah.
But there's some people who maybe,
Yeah, I think it's a really important point that a patient would have to have with their doctor, and preferably a doctor that knew them well and knew how they thought, knew what their values were. There is, of course, the radiation exposure. There's a little bit of a hit to your kidneys from the contrast dye, which, if your kidneys are well, you'll bounce back, and that's not an issue at all. There's the anxiety of knowing. There's the anxiety of not knowing.
Yeah.
It's really
it's a complex
Yes.
thing to think of.
Yeah, absolutely.
And again, it ties into how people often oversimplify things or do things because they saw it in the latest whatever craze, social media, something.
Yeah.
Medicine's often more complicated than that, and there's a lot of things that need to go into decision making.
Absolutely.
With a patient in front of you.
Yeah, and I think one of the most important jobs of a doctor, beyond being knowledgeable and logical and ethical, is to aid someone in their decision making.
Yeah.
To be a partner in those choices.
Yeah. So what I'm taking there is, I guess, context matters between obviously knowing the patient, knowing their history, knowing their risk factors, and then probably flagging certain risk markers on lab tests or things like that from a cardiovascular perspective.
Absolutely.
Yeah. Okay.
Although, on the other hand, if the risk markers were there, quite clearly someone were hypertensive, high ApoB, family history of cardiovascular disease, relatively young, it doesn't necessarily mean we have to go straight to angiogram, because either way we know what we need to do.
Yeah.
So begin addressing those other issues. At some point, though, we would want to know where we stand.
Yeah. Yeah. Even just from the perspective of knowing if your treatment is doing what it should.
Yeah.
Yeah.
And I think also for patients, if they're unsure, it's important for them to know they can get a second opinion. They can speak to another GP. They can ask to be referred to a cardiologist or a lipidologist and have this level of conversation and really help with their decision making.
Yeah, I think that's an area where medicine needs to improve a little bit, because I think historically it was very hierarchical.
Yeah.
And so like it was somewhat dictatorship like. And I think medicine is evolving, and it has been for a long time.
Yeah.
It depends on the doctor, obviously, of being more patient-centric and more of a sort of joint collaboration and helping and informing, and we've talked about that a lot as well.
Definitely.
There's one other test that you're probably one of the only doctors locally here, and maybe one of the only few in Australia doing in relation to cardiovascular health, that I think a lot of people are probably not familiar with.
Yeah.
And I think it's important for myself because I'm probably on that higher cholesterol side, but the high blood pressure thing is a problem where we're looking at, the pliability and health of the endothelium and the blood vessels itself. So you're doing something called pulse wave velocity analysis. You want to tell people a little bit about that? Because it's a really, really interesting test that I think a lot of people probably have never heard of and are not familiar with, but yet, from my understanding, like quite valid and clinically important information you can get from it.
Absolutely. So pulse wave velocity is literally, as it says, the velocity that the pulse wave moves through your arteries. That doesn't mean that's the speed your blood is moving, but the shock wave that's moving through your blood. It's a little bit like, analogously, there's the speed of sound and the speed of wind. The wind is the air actually moving. The sound is the shock wave moving through that same air.
Yep.
So we use a device that can measure the speed of the shock wave going through your arteries as your valves close. And the stiffer your arteries are, the faster it reverberates down your arteries. You can imagine it like, maybe waves bouncing off a pier. And if it's really hard versus if it's pliable, you're going to get a different response.
Yeah.
But that's the speed of that shock wave is a very good proxy for the pliability or stiffness of somebody's vessels, which is great proxy for cardiovascular age and risk factor overall.
Yeah, being that a stiffer artery or blood vessel is going to be more prone to deterioration over time, that may lead to atherosclerotic plaque and etc.
Yeah. It's of an older phenotype.
Yeah. So ideally, we want to have
young, pliable arteries.
Yeah, fantastic. And that one is interesting because most people will just go get their blood pressure. And so I guess what's the value and the difference in if I just get my blood pressure, my blood pressure might be normal or it could be high. How does pulse wave velocity add more nuanced information there for you to sort of dictate treatment?
So our same machine, in addition to the velocity, also does a pulse wave analysis where it uses calculus to back impute the components of the measured wave. So it can extract out what piece of the pulse wave is reflection off your aorta versus the closure of the valve versus the contraction of the heart. And it's amazing. And it can give you a very good number for the pressure in your aorta, which when we get our blood pressure done, we do it here in our arm. And the assumption is it's at about the same level as your aorta. So at the same height, the pressure should be the same. It works whether you're lying flat or sitting up. But because of vascular resistance and other factors, it's not always the same. So a good pulse wave analysis machine can tell you what your pressure is here, which is the number that prognostically matters more than the number here in your arm.
Yeah, fantastic. Yeah, and I think there's, how many in Australia? There's not many people actually.
To my knowledge, I don't know specifically. I do know of one excellent GP in the Gold Coast who has this machine, and he inspired me to get one for our clinic as well.
Fantastic. And obviously you've got one. So anyone listening, watching, if you want to get a pulse wave analysis and velocity done, then they can see you.
Absolutely.
Which will provide, of course, all your details and everything towards the end there. Okay. Well, we've covered quite a bit. There's one other one that maybe people are familiar with and we've talked about before, which it's an interesting one and there's more data kind of growing. It's whole body MRI. What's your perspective on whole body MRI?
Complicated and nuanced. So
like most things.
Most of the medical establishment is against it in principle en masse, and I would have to agree with them.
And is that because, from what I understand, there's a high false positive?
There's a very high false positive rate, definitely, in the order of about 30%. And just a blanket MRI without really knowing what you might or might not be looking for is quite likely to miss some things.
Is that does that dependent on the radiologist though, or is that just the nature of the assessment?
It's dependent on the radiologist, how the diffusion is set for the machine, what artifact is and isn't filtered out, the advanced programming behind everything the machine's doing. So there's that. Where were we? Okay, so
you were saying that as a blanket, they don't recommend it.
Don't recommend it. And I would have to agree. If everyone just went out to Q-scan and just got an MRI, it would be in 1 centimeter slices. Suddenly 30% of the Australian population would be struggling to follow up on incidentalomas that are most likely benign. Your likelihood of actually finding something of value is significantly lower. So if you're going to do this, it's really important that you do it in an excellent imaging clinic that's going to take all that into account. The clinic we partner with, Brisbane Radiology and Mermaid Beach Radiology down on the Gold Coast.
Has the Brisbane location open now?
Just.
Okay. So at the time of recording, what are we now? We're Feb 12th, 13th, 2024. So that's great.
Definitely, wide open. They slice at 2 millimeters, ultra high resolution. They have a full-time nuclear physicist there on site to modulate every scan and all interference. No two people are getting the same scan. Their radiologist is phenomenal. He only reports these things on a weekend if he slept well and his kids are quiet, because he doesn't want to dare miss a single thing. It's that level of detail going into it. And if you're going to do this, you have to do it to that level of certainty and precision. Otherwise, you're wasting your time and money and causing yourself.
And that's another thing I think people don't understand in relation to this technology is an MRI is not an MRI.
Yeah.
Like there's
it's not like a
different
Polaroid.
levels. Exactly.
Yeah.
The technology can be different. The equipment can be different. Obviously, the radiologist and the person interpreting it, they can have vastly different levels of knowledge and how to actually discern the information. So if you're going to get it done, it sounds like Mermaid and Brisbane Central has pretty good aspects of actually getting it done.
Frankly, I don't think I would be using this modality if not for them.
Yeah, something that I'm definitely keen to go do and try, just because I think, as we talked about, cancer is sort of one of the big ones. So if you have anything that can at least potentially pick something up, then that can be really valuable, because we know the earlier you detect it, the much better likelihood of you surviving it will be. If you catch it stage 3, stage 4, like for most things, you're pretty out of luck.
Absolutely.
But if you can catch it early and that preventative approach, then your likelihood of living is going to be much better.
But this is important not just for cancer, but a whole bunch of other screening modalities. So we can screen for aneurysms, liver fat percentage.
That's right. Yeah, the aneurysm part I forgot about as well.
Muscle infiltration and brain fractionation. We can snapshot exactly how much gray matter, how much white matter, how myelinated your white matter is.
Amazing.
And if that's changing year to year, we might know to act sooner rather than wait a decade until behavioral changes present.
Yeah, well, all right, you've sold me now. So definitely, by the time I hit 40, I've got a long list of things that I need to make sure I get done now.
We'll get you there.
Yeah, and I think that's a big one. And I'm glad you added some of the context and nuance there, because, again, for people who are in the space of longevity and maybe read Peter Attia's recent book, he does talk about whole body MRI. So I think it's important to give people more information about pros, cons, how to get it done properly. The other one there, which we won't get into too much, is the liquid biopsy, which seems to be still quite new.
Quite new. It can be done here in Australia.
There is a place.
Okay.
Yeah,
we've worked it out.
Fantastic.
And prior to a full body MRI, it can add some context. If something does flag, then it allows the radiologist to focus in a little more on this or that.
Amazing. Yeah. So it sounds like we've got a lot of tools now that are growing in the preventive space. But as I kind of referenced at the beginning, none of these are covered through insurance.
Nope.
So unfortunately, if you want to kind of go down that path, it's out of pocket at the moment.
Unfortunately, it is.
Which, that gets into the conversation of, what are you looking to pay, or what are you willing to pay for your health in the short term, knowing that hopefully it saves you a lot in the long term. I think a lot of people see a couple $1,000s and they say that's too much, but yet in a matter of a couple months we'll probably spend that on clothing and going out and alcohol and different things.
Or patching up the car they drive in. You get one scratch in your car, you're going to go pay a few $1,000s on body work.
But then down the line, because they didn't take this preventative approach, they could end up spending not only on themselves tens of thousands of dollars on medication treatments, plus the headache of it all, but then also a huge cost to the medical system.
Although I don't fault most people for this, because there's a lot of predatory medical scaring out there, and people don't necessarily know how to navigate this space and who to trust. And
which is why it's important to have a doctor that's at least trained somewhat in the longevity space versus sort of picking up stuff from the internet and trying to piece it together yourself.
There's a lot out there.
There's tons. There's no shortage of stuff now. Okay, well, that gives a really good synopsis. I'm sure we could probably get into more nuance there, but I do want to get around some of your strategies around how we actually go about then implementing things that are going to help improve life. And I had a couple of things. We talked about some of the lifestyle components. So, sleep, stress, those general items. And sleep and stress, if you want to get more into those, I find are often undervalued quite a lot. I think a lot of people talk about nutrition and exercise more now. Like we said, exercise is growing. But the components of good sleep, circadian rhythm, and good circadian biology, that's growing. But again, I feel like it's in niched areas, and I'm probably in that echo chamber where I find it important. So I learn a lot about it, but the vast majority of people are still not very familiar. So where do those tie in, and how does that tie into, I guess, overall sort of now practical approaches of improving components to optimize longevity?
Absolutely critical. Sleep is huge. I think it's not as emphasized because we just don't have as great of tools, and to a lot of us it's elusive. You come to me and you're like, all right, how do I get into the 80th percentile of muscle mass and the 97th of VO2 max? I've got a plan. We'll get you there. You come to me and say, I can't sleep. I'm like, yeah, me either. I don't know. We're still trying to figure this one out. So It's a lot more nebulous of a space. I mean, there is a lot that we know that works. There's Matt Walker's amazing book, Why We Sleep. I think that's pretty foundational.
Yeah.
Recommend it to most patients who come to me and
Yeah,
say,
great.
I can't sleep. That's been wonderful. Stress, I don't know what to make of that. There's so much contradictory evidence that, there's some evidence that it's the number one killer, and then there's other really good evidence that it only does to you what you think it does, and if you feel like the stress is going to ruin you, it ruins you. If you feel like the stress is going to help you thrive, it helps you thrive.
Yeah, that's such an important component. And this is the nocebo effect playing a role too, right? Like, I think the aspect of belief and expectation is such a powerful influencer on health.
Yeah.
People don't realize how much their thoughts influence their physical
Absolutely.
well-being.
Absolutely.
And Bruce Lipton, I think, was sort of the early pioneer in the space of biology of belief, and how belief actually influences epigenetics, which then leads to a cascade of physical changes. So it's a huge, huge part. But it seems...
I'm stress agnostic.
Yeah. It's interesting to say that, because before we talked, I would have automatically said, chronic stress, bad. But I guess the context and nuances there, I still think the aspect of chronic stress that we see in westernized sort of modern worlds now is detrimental.
If it's manifesting in not sleeping and chronic hypertension, indisputably that's bad.
But I think even from a physiological perspective, from an evolutionary view, we traditionally didn't live such hectic lives, right? We didn't have all these chronic stressors.
We had acute stressors.
Exactly.
Yeah.
And quite significant acute stressors, like death and constant warring and whatever.
Yeah.
But we didn't have, bills to pay, mortgages, commutes to work, two parents working while trying to have a family.
Yeah.
All of these sort of ongoing things now, which are a stress on the system, which activates the HP axis and has all these effects. So, and who's the author? Hans Selye, who pioneered a lot of the work around stress and stress physiology. I think there's certainly an argument to be made for it playing a role.
Yeah.
But then there is the perspective of how you perceive that and your ability to, I guess, frame the stress in a positive or negative light can definitely shift someone's perspective. The other part that ties into that, and we talked about this in relation to even blue zones and stuff, was the aspect of community. And there's other sort of factors where I feel like there's so many more other confounding variables or other factors which are important when looking at longevity in the blue zones that are probably more important than the traditional stuff people focus with. Now, you've done a fair bit of sort of picking apart the blue zones. A lot of people are probably familiar with that. So what's your sort of perspective on it?
On the blue zone specifically, is stress relative to...
I guess blue zones overall, and we can kind of pick apart what are the things that are actually potentially influencing longevity in those spaces. Is it actually these places where people are living longer? There's a lot to pick apart here.
Yeah, there is definitely a lot. I think the first thing, and just stepping back a little bit, I'm a little bit stress agnostic, but there's no point in living a long life if you're going to be stressed out and miserable. So as much as I'm not 100% convinced on exactly how much it correlates with longevity, you don't want to be miserable and live a long life.
But interesting, and this is something I think about a lot these days from a philosophical perspective of a life of meaning as well. And so in the modern day, we seem to have completely shied away from difficulty and being uncomfortable. And sometimes, a life of meaning, which is, I think, what most people should strive for, because otherwise, why are you here and living? People move away from discomfort and avoid stress, but often things that are meaningful come with stress. So I feel like there's a perspective where we need a little bit of that to know that we're here, we're alive, we're doing something meaningful. So I think there's definitely a happy medium with those.
Yeah, definitely. So, but the blue zones, that's... we could do a whole
Just
podcast on the blue zones. So straight up, I think the blue zones are a complete fraud.
Excellent. And
Just
that might be
putting my
shocking
cards
for a
on
lot
the
of
table.
people. I support that claim.
Yeah.
It might be shocking. And we can always share
Yeah.
references and things that we talk about as well if people want to learn more about it. Give them at least a synopsis.
Yeah. So in 2009, Sol Newman out of the Australian National University used some pretty great statistical mechanisms to prove that the disproportionate number of centenarians in the so-called blue zones were from clerical errors and pension fraud. Wonderful
So there
study.
goes that whole thing.
There goes that whole thing. But that backs up a 2010 finding out of Japan that 230,000 would-be centenarians were actually long dead while their families continued to collect their pensions.
Remember when you sent me that? I was dying of laughter.
Yeah.
I've heard as well that there's a lot of areas where they actually don't have very good record keeping.
Yeah.
And so they had actually
the clerical
misrepresented.
errors.
Yeah, they just totally misrepresented their actual age because there was no admin, there was no clerical stuff going on.
Yeah.
Yeah.
Yeah. So that's an issue in itself. But let's just assume even that didn't happen, and in these 9 or so blue zones there is a disproportionate number of people living to 100. So let's just give it the benefit of the doubt. The average age of those populations, though, is still well under the longest lived countries. You've got Liechtenstein, Macau, Hong Kong, places where people are outliving anyone else in the blue zones on average. Yeah. Macau's life expectancy, 89 years old on average, far higher than Okinawa on average. So even if the data out of Japan were true, the interpretation was wrong. The interpretation should have been there's a disparity causing factor where, for whatever reason, a tiny percentage of these people are living to 100 with more frequency than the percentage of people in Monaco.
Yep.
Well, the majority of people are dying younger. So the lesson to be learned isn't let's go do whatever they're doing in Okinawa. It's let's do whatever they're doing in Monaco, because say it's a micro percentage of people, even let's just say 1% of people living past 100 in Okinawa versus 0.5% in Monaco. You're still, if you do what you're doing to assume that phenotype in Okinawa, you're still not, you're doubling your percentage of living to 100, but it's, still not great. And you're throwing away your likelihood of living to 89, which, it's much more probable. Yeah. It's like playing a bad lottery and a slightly worse lottery.
Nice, good analogy.
So I think, the blue zones were based on clerical errors and pension fraud. But then I think there was academic fraud in coming up with the thesis by deliberately misinterpreting the moral of the story. Mm-hmm. Kind of like the tortoise and the hare. It's not that slow and steady wins the race, because you put those two on a rematch and that rabbit's never going to lose again.
Nice. Yeah. And there's so many difficulties with trying to have nuanced and context specific chats when we're talking about science, because unless you've had a science background, a lot of people are not going to understand a lot of these things, or a statistics background, because obviously there's a lot of things that can be done with statistics. There's a growing issue of p-hacking and all sorts of things now where people are sort of modifying things to suit what they're hoping to find. And so a lot of the general consumers, you can't blame them for sort of going with the narrative, because it's very difficult to, I guess, read the leaves and see what's actually going on if you don't understand.
Absolutely. You can pull up a study online to support any position you have.
And now they have the predatory journals too. So these predatory journals are like just basically BS journals that people are releasing with their own funding to support their own claims. They're not peer reviewed. They're not actually really well done studies at all, but yet you could find it on PubMed, right? So,
and then you've got to consider all the studies never published because it found nothing. Which I think should be news.
For sure.
For sure. You do 100 studies that find nothing. I think that's pretty definitive, but that stuff doesn't get published. And it doesn't mean throw the baby out with the bathwater, because a lot of people hearing that will go like, oh, well, then all science is BS. Well, no, it's the best tool we have. You just have to know and understand how to discern good science from bad science, which that's not always easy to do. But there is at least a hierarchy, which we know, meta-analyses, systematic reviews, etc.,
versus say, expert opinion, but that's another thing we could go into. The one thing I always found interesting with the blue zones and also now in this whole longevity space, which I sort of referenced at the beginning, is the protein perspective, right? So everyone was like, protein's bad. You want to reduce your insulin signaling, you want to reduce muscle mass, do a lot of fasting. But for me, that was always somewhat counterintuitive to the aspect of maintaining muscle mass and muscle density and reducing frailty and staying healthy. And even the blue zones in a lot of these places, and even the China study going back ages, which has been also debunked a million times, a lot of these cultures actually consume copious amounts of animal-based protein. They're not plant-based, but yet the narrative went that way. So I'm curious, I guess, what your perspective is on, animal-based proteins, animal-based foods in relation to longevity, and then particularly around protein itself.
Yeah, I think number one is the basics. We know for a fact muscle mass and VO2 max are the two measures most correlated with human longevity. That's indisputable.
And healthspan. And I think that's the thing that a lot of people don't talk about. So sure, you might extend your life another year or two, but if you're completely frail for those 2 years, was that worthwhile? And
was it worth it? But the data isn't even that you're going to extend your life a year. So there's very good mechanisms showing that excess protein or more regular protein ramps up mTOR, which is the pathway that accelerates aging. I can't argue with that, but that's just a cellular mechanism that leads to a few different things, and it's not the overall big picture outcome. And we know the overall big picture outcome is that the more robust an old person is, the better they're going to do.
Exactly.
They're not lab mice in a sterile environment.
Yeah, I think that's where often things go awry, because you have scientists who are maybe well-meaning in a lab doing research who are not clinicians, right, and are not taking that context into the real world. And so I feel like a lot of the things in the longevity space at the moment are derived from scientists doing interesting studies, but it's often, it's just in vitro stuff, or now in silico, or it's rodent models, or it's certain things which then, when it's done in human models, doesn't translate, but yet it still holds. And so a lot of things, even like the resveratrol and stuff, it looked really promising. Then they did human studies and was like, doesn't really do much, and probably the amount you need is so ridiculous, but even then, does it really move the needle much? I feel like people, I don't know, they get stuck to that, and the scientific perspective doesn't translate clinically, but yet it just keeps running.
It's not that it's bad data. I think it's great data. I think
it's good
really
data.
Exciting. But it's like the blue zones data, where you look at all the data and you can actually make the wrong interpretation and actually get steered in the opposite direction you should be going, because you're just not considering the big picture. Misinterpreting a fable. Yeah,
and that happens often. And so the mTOR thing, that's obviously one of the big components in longevity that people are targeting. And there's so many ways we could go with it. But so mTOR signaling, for those that don't know, sort of provides a cascade where then we have an anabolic response, helps build muscle, does various things for us to maintain muscle mass. But then there's the side where they say less mTOR signaling seems to be associated with longevity. What's your perspective? Why is there a disparity there?
We know suppression of it can lead to a longer-lived phenotype, but again, these are in very measured laboratory conditions. You could take an example with a drug, for example, rapamycin, used in humans to suppress mTOR. And if I were to just give you rapamycin continuously, you wouldn't do great. You really wouldn't be doing very well. Conversely, best evidence in organisms is pulsatile suppression of mTOR. Seems to be playing some effect in longevity. And there's thoughts on the nuances of senescence and this and that. The answer is always more complicated than you think it is.
I think the pulsatile component is important. Is it sufficient to just have a normal diet where you're eating 3 meals a day, is that reduction in mTOR signaling between meals, is that sufficient, or does it have to be extended fast, right? Because this is one of the reasons why people do extended fast or protein modifying or protein sparing fasts, where they're trying to reduce that mTOR signaling, also enhance autophagy and reduce senescent cells.
I think the truth is we don't know yet, and there's no way to know yet. There's no way to measure this. But if I could have a patient that would happily just eat 3 really healthy meals a day, exercise, do everything right, I couldn't care less if that person isn't fasting. Like that's, as far as the hierarchy of priorities go, it's not even on the table. On the other hand, if we have people with profound metabolic illness, profound insulin insensitivity, fasting is a very important tool we can use. And then you take the ancestral viewpoint, you could imagine in our wild ancestral lives, we would gorge on protein and then probably fast for days until we killed another animal. And it would be spikes and drops and spikes and drops.
Yeah.
So certainly we're adapted to it. Whether that then conveys a longer lived phenotype versus a more robust phenotype, or we just got by, humbly, I have no idea.
Yeah, I'm glad you say that, because I'm still, we've talked about this plenty offline, I'm still of the same nature. For a while, I was doing intermittent fasting and sort of scheduled regular fasts.
Yeah.
A long time ago, probably almost 2 years ago now, I moved away from that. And now, again, a lot of the other experts, even yourself, but Rhonda Patrick, who is a big proponent of fasting, Peter Attia, they've all sort of moved away from the intermittent fasting perspective as well, because it comes at the detriment of maintaining muscle mass.
Yeah.
And so my perspective now is, if you're a lean, healthy individual, you get enough benefit even with autophagy. So there's been studies now looking at exercise has a more robust autophagy signal than fasting.
Absolutely.
If you're healthy, lean already.
Yeah.
So why do you need to fast, which will potentially have detriments, especially if you're a skinny, scrawny guy like me who can't maintain any weight? Why would you, throw out the potential of maintaining the benefits of good muscle density just to do that? I don't think it's worthwhile.
Agree.
Whereas, I agree. I think in the context of metabolic syndrome, obesity, those types of things, that definitely serves a role. But most people in the longevity space, they're already healthy, fit. They don't have underlying morbidity.
Yeah.
So my perspective now is, I think it's somewhat of a waste of time and a net negative to actually do that.
I will say it's become very convenient to take that viewpoint. And
however, there is one perspective where I think fasting can be very profound, and that's self-regulation.
Yeah.
And it's the same as ice baths. I think the most powerful benefit of ice baths is the cognitive perspective of developing self-efficacy and
you can do it.
Overcoming discomfort and knowing it's going to suck, but you do it anyway. I think there's a lot of benefit in doing that, especially for people who maybe are struggling with those types of things.
Completely agree.
That part I can see there, and I'm still playing with the idea of maybe still incorporating like a random fast here or there, whether 24, 48, 72 hours, but it would be more like on a whim. Maybe I just don't feel like eating or whatever. I'm definitely not structured fasting anymore.
I will say one other aspect of it is almost an audit of your metabolic function. You have to be pretty healthy to do it comfortably.
For sure, if you're having glucose excursions on a roller coaster and then you try to fast, you're going to be very unhappy.
Yeah. So I think of it almost like running a marathon, where you have to be relatively healthy to do it, but doing it every day is not a healthy thing to do. Fasting, you've got to be pretty metabolically flexible to do it comfortably, and it does feel like a superpower when you're a few days in and it's like, I can breathe underwater. I can go without food.
It does have that
just
sensation.
Fine. But you've got to be relatively well to be in that state.
I think that's the key thing, is metabolic flexibility. And more people are moving in that space. It used to be like, you have to be keto or you have to be this. And I think where we're seeing now the data shows, again, humans wouldn't have survived all across the globe if there was only one way of eating.
No, we're like raccoons and cockroaches. We'll make it work.
Yeah, whatever's around us, we can make it work. So you need to be flexible. You need to be able to metabolize and utilize carbohydrates and glucose. You need to be able to use ketones every now and then and fat as a fuel. So I think having that flexibility is super important. And again, it can come as a tool for there. The keto space is interesting because I've read a lot of papers around ketones as sort of like an anti-inflammatory and also an epigenetic regulator and a signaling molecule in relation to longevity. So I think still more research to be done, but there's early stuff looking at potential benefits of ketogenic diets to overall health and longevity. So there could still be benefit there. My perspective now is I kind of hack it and I look at just taking exogenous ketones. So I get the benefit of the ketones without having to do keto. Do you have much to sort of add into that?
I'm going to humbly say, I don't think we really know, but it's so much fun that you and I get to play around with things like this. We know what the basics are, the absolute foundational pieces of longevity, and then we get to go into the weeds on the rest of it.
And again, I think that's where people take the longevity approach wrong, is they start with those things and the basics go out the window. Whereas when the basics are good and the foundation is strong, then it gives you so much more flexibility to try different things and actually see what works and what doesn't work.
You're crazy like us and you're into it, and if you're not and you just want to stick with the basics, you're doing it right.
But that's probably a good segue then to some of the more nuanced things. We've already talked about rapamycin. I'll come back to that one because I think for both of us that seems to be a very promising one. But there's some other molecules in the space. What's your perspective? Do you have like any views on some of the supplements or medications in the space? So there's obviously things like metformin, which was popular for a bit, which now that's shifting. There's spermidine, there's NAD, people are doing IVs. There's a few things we can dive into there.
We could go in so many different directions. I'm going to say NAD, the jury's still out. I don't feel like it's worth my time to go into the weeds on it.
Time and money as well.
Absolutely. IVs, I think that is a really important thing to touch on. So IV bags and lines are made with phthalates, the same stuff we try to avoid in the fancy shampoos we buy and the expensive reusable mugs we buy to avoid phthalates and the liners and this and that. The lines, I think it's up to 40% of the material that the line is constructed of is a phthalate.
Sent me that information. I was just flabbergasted.
And you lose up to 12% of the mass. Direct line injected into a person. I'm not saying don't get an IV if you're in hospital. We use them all the time.
Life-saving utilization versus like, I'm going to go get my NAD IV or I'm going to go get my Myers cocktail or my B vitamins just because I feel like it, or to make up for my lifestyle choices of drinking and partying.
Exactly. And if you really want to take those supplements, if you can take them orally or a direct intramuscular injection, do that. The IV is the stupidest way to get it into your body. That being said, if you're in hospital and they think you're going to have a kidney injury or an arrhythmia, let them want to put it in. I wouldn't hesitate.
And so again, for those listening, phthalates are a really well-known endocrine disruptor. One of most profound. That's often in a lot of things like things with perfumes and scents and stuff like that. But so it drastically disrupts your natural endocrine systems or your hormones. And now we're finding that some of them may be obesogens and they have potentially other issues, carcinogenic, and those sort of things. So a lot of people that are buying their organic shampoos and they're free from this and that, moisturizers, they're doing all that, but then they're going in straight lining a significant amount of phthalates by getting their, sometimes for some people, weekly IVs. And
they've more than undone all their efforts to avoid phthalates.
So as a general statement, at least for the moment, definitely avoid IVs until we come up with some better...
So there are phthalate-free lines and bags. There's 5 companies out making them. I don't think anyone really knows the depths of the phthalate alternatives. I don't know if they've been studied properly.
That's one of the concerns, right? It's the whole BPA thing too. So BPA free, but then they use BPF, BPS, which hasn't been studied, and for all we know, maybe worse.
But I will say, there might be options out there if you're absolutely convinced that's something you want to do.
But for the most part, most nutrients that you're going to be consuming from a health or wellness perspective, like your absorption orally, is more than sufficient. Even for people who are maybe borderline deficient, often within a couple of days you can become replete perfectly fine just through oral use.
Absolutely. I mean, there are times we'll do direct injections, like injections of iron, for example. That can be really important, and it's certainly worth the little bit of phthalates that comes through on the line in the bag in those cases. People
who overt deficiency, there's still some issues with that. Like iron, especially, and there's so many women now suffering with iron deficiency. They're like, oh, I'll just get an infusion every couple of months.
It's not a good strategy.
If you're getting the infusion through, again, IVs, you're getting the phthalates but you're also straight lining a super oxidative mineral into your bloodstream, which then causes massive oxidative stress, a bunch of inflammation. So it's not a very good long-term strategy. And as a patchwork band-aid, it can help a lot of people, but it sounds like overall not the best approach.
No, not as a long-term strategy. Certainly not.
Yeah, excellent. I think that's going to be valuable for people.
Yeah.
And it's always tricky because, things, I feel like there's that white coat syndrome where things that appear very medical, people buy into really well. So like if it's a needle, it must work. If it's some test, it must work.
Well, also ironically, hating modern medicine and everything we have to offer with all our medications and this and that.
Yeah, there's also that side of it as well. But there's a lot of things that are practiced standardly in private practice and wellness clinics that are not actually like clinically validated or based on really reliable research. And I think it's important for people to know that, because what they might want to be doing for their longevity might have the opposite effect. And it might actually set them up to have early issues.
Absolutely. So I will say, if anyone's in doubt, just go back to the basics.
Yeah, fantastic.
Muscle mass, VO2 max, good nutrition, good sleep, reasonable screening.
Can't go wrong with those. I think the screening part, and that's why I emphasized that at the beginning, that's such a valuable tool, and most people, again, sort of wait until something goes wrong to see their doctor. And so personally, I always tell any of my patients or clients that like you should see your GP and just get some general
yearly checkup.
Get some bloods done. At least you see a trend line. You can maybe pick up things early. Like, don't wait until something goes wrong. Jump on it sooner rather than later, and then you serve yourself really, really well.
Absolutely. Absolutely.
Fantastic. I know we're on the same page with that. Well, I'm sure I could pick your brain for ages, and maybe we'll have to do a follow-up. Oh, actually, before we close, I did want to jump into a few of the other nuanced things, which is where we started. So metformin and rapamycin.
All right. Metformin seems to have not panned out to what it was believed to be. I don't think the TAME trial has been published yet. So
I haven't seen anything released on it. It'll be interesting to see what
We'll wait and see.
But based on like some earlier literature that's come out now, it seems to be not so beneficial. Definitely, again, in people who are already relatively healthy. Maybe benefit in people with metabolic syndrome, diabetes.
And I mean, even if just a short course for a couple of years, 6 months, get them through it. But for some people, as a lifelong medication, it is wonderful. But as
healthy person
metformin in the drinking water, I don't think so.
Okay. And I know that there was that recent literature that came out that showed it may be detrimental to the mitochondria as well, and reduce ATP and energy production, which obviously that kind of ties into some of the aspects and hallmarks of aging. So it sounds like metformin for a healthy individual, probably not.
I wouldn't bother. At least not yet. Again, that's getting into the weeds of the weird and wonderful, and it's looking unlikely, but maybe. But just go back to the basics.
Okay. Well then, rapamycin, because this one does seem promising based on some recent research and ongoing research. So what are your perspectives there?
I'm excited about it, frankly. There's some really interesting rapalogs coming out, some good human data showing increased immune response post-vaccination, things like that would suggest that person is having the immune system of a younger phenotype after pulsatile dosing and washout. There's great studies on dogs and
that's been a big one. I feel like the dogs and all the people with their beloved dogs are going to get that soon. And I feel like for humans, we're not going to have it for a while.
Look it up. There's websites promising you rapamycin for dogs. I don't know if you're actually getting rapamycin for the fortune you pay, but you can go buy rapamycin for your dog online right now.
Of course. That's the way we go with things. So rapamycin seems to be promising, but from what you were saying before, in a more pulsatile use.
That's what the best evidence is showing, although there's some other evidence showing continuous low dose. Humbly, I'm just going to have to say I don't know, but I'm eagerly watching this space.
More research needs to kind of come out and see what we do. Well, I know we've talked about you potentially trying to organize a bit of a research project going on with rapamycin and some of your cohort. So it'd be interesting to see if we can get something like that going in Australia and
That'd be
organize with some of the
fantastic.
Universities and things around.
Absolutely.
So you've got a good contact who's also interested in that space.
Yep.
Which maybe we can have a chat with him at some point.
Yeah, Julio, you should definitely have him on.
Yeah.
That'd be fantastic.
Yeah, I'd love to. I'm sure I can pick his brain about all sorts of things.
Yeah.
Yeah. Excellent. Well, maybe we'll leave it with there. There's probably a few things which we can talk about again, like the whole aspect of senescence, the SASP, immunosenescence, those sort of things, which we've kind of mentioned here or there, and autophagy. But we can maybe say that for a later one. Is there any sort of closing remarks, anything you want to add in for people as far as a longevity perspective?
Longevity perspective. Yeah, don't take the amount of time we went discussing the fun, weird, and wonderful as proportional to the amount of effort you should put into that weird and wonderful relative to the basics.
I feel we did at least some justice to some of the foundations. I feel most people, and it's probably something that often needs to be reiterated, but most people know and understand some of those things. They don't necessarily apply them.
Yeah.
But yeah, they are pretty straightforward. But it does always play a role to reinforce the significance and the, I guess, magnitude that they can actually play in enhancing your longevity.
Yeah, absolutely.
Fantastic. Well, thank you, Simon. If people want to sort of find out more about you or work with you, where can they kind of connect? And
we've got our clinic is run out of Total Fusion here in Australia. If you just look up Total Fusion Platinum or Total Fusion Newstead, you'll find links straight to our medical practice, and we'll go from there.
Yeah, fantastic. Which is probably one of the nicest facilities, I would say, definitely in all of Brisbane and perhaps all of Australia. And I think you have a full suite of other practitioners there. Obviously, there's yourself, specializing in sort of longevity, metabolic health, but there's a whole range of allied health and recovery services and a full suite of
We've got it all.
Yeah.
We've got something for everybody.
Yeah, fantastic. Well, I'll make sure to link all the details there so people can see more and learn more about you. Do you have any socials, website, anything for people to follow, or is it more through the clinic?
As your viewers might have gleaned by my bio, I spent a significant amount of my life trying to avoid digital footprints.
Fantastic.
I have just dipped my toes into LinkedIn this late in life. I'm like the grandpa eventually discovering Facebook. So we'll see by the sequel how far into socials I get from there.
Yeah, excellent. Well, I'll put up Total Fusion's details there and people can find out more there. I hope you enjoyed that episode. As usual, everything will be in the show notes and the description below, as well as any links to the things that we talked about. If you want to support my channel, make sure to like and subscribe so you don't miss out on any future episodes. We'll see you in the next one.